we've got PTs, all kinds of folks that really know medicine well. We felt like we had a really great handle on his physical recovery, how to support him through those challenges. But the thing that I could not wrap my head around was the mental health tunnel that he would have to go through in order to recover. So he was gracious enough to allow me to share his experience for this presentation. So thanks, Tony. There we go. So I'm a speech therapist. I'm not a mental health expert. This presentation relies heavily on the work of the gal who literally wrote the book on the topic. Her name is Michelle Flaum Hall. She experienced medical trauma herself and is a mental health professional. But this quote kind of exemplifies the goal of the presentation. The goal of her work and this talk are to help practitioners like us who work in the physical health space better understand the mental health needs of our patients so that we can make appropriate referrals, offer mental health first aid, and identify symptoms that stem from trauma rather than misclassifying them as behaviors. So through this talk, we're going to kind of talk about what medical trauma is, factors that contribute or are protective against the development of medical trauma, and the best part, interventions. We'll kind of dig through some case studies so you can kind of see how this plays out in real life. There are a lot of search terms you might find if you're looking up medical trauma. Medical trauma itself is the psychological impact of a medical event. It stems from direct contact with the medical setting. It does cause physiological changes in the survivor, and it is subjective. So it's defined by the person who has the trauma. You might be most familiar with the term PTSD. Some folks are calling it PTSI or M for medical PTSD, but we're going to contrast that with some of these other terms. Acute stress disorder is sometimes a precursor to PTSD, and it will be important for you to be able to identify that when we're talking about interventions. The terms at the bottom, PICS or ICUS, those are specific to critical illness. Some articles you might see have that as a search term. My favorite term on this slide is enduring somatic threat. That's the concept that some medical trauma goes with chronic illness rather than an acute or discrete event. So we'll discuss how that's important for identifying these issues here in the future. So how does trauma develop in your patients? First, you'll notice that there's an acute stress reaction. The main feature for that is disassociation or sort of shutting down to your environment. There might be anxiety, intense fear, or helplessness, but that disassociation is the main thing to look for. If that is prolonged for a couple of days up to 4 weeks, that can be an acute stress disorder. And then over time, that may develop into PTSD or that enduring somatic threat, which can be a lifelong issue. One does not need to have an acute stress reaction or acute stress disorder in order to develop PTSD, but there's a high likelihood that if you have some of those dissociative symptoms, that you may develop PTSD. Scientists' understanding of PTSD has really shifted over the years. Up until 1994, it was only thought that PTSD would develop from a discrete event. But at that time, chronic illness was recognized as a qualifying event for PTSD. The big 3 symptoms here are things that we're going to talk about a little bit more: hypervigilance, avoidance, and intrusion. And when it comes to medical trauma in particular, those things play out a little bit differently. Hypervigilance and avoidance can actually interact with someone's medical conditions, and intrusion might not be a great descriptor of medical trauma for reasons I'll show you here in a minute. So how is medical trauma different than more traditional PTSD? First, it's contextual. It's found in I don't just mean it's found in the hospital or clinic, but it's an experience that's in the healthcare system. It's a relationship between the patient and the protocols and the systems of medicine. Secondly, this little word here, biopsychosocial spiritual, describes all of the domains of self that can be wrapped up into a medical event. And thirdly, it occurs on a continuum. There's different levels of trauma based on what type of experience the person has had. That continuum looks a little bit like this. There may be a planned or routine intervention, getting shots, having dental work done, a birth of a child, but that can still result in a traumatic event for the patient. There could also be a life-threatening or a life-altering diagnosis or even a medical emergency, which does not result in trauma for the patient. So just because you're doing something that's routine and regular for the patient, there is a possibility based on their factors and their personal experience that could cause trauma for the individual. There are different domains that Michelle Pflaum Hall identified are affected by trauma, by medical trauma in particular. And the reason I point these out is we'll hit them again in interventions, but you can see how your work may interact with these different domains. How are they spending their leisure time differently after their medical event? How are they communicating or interacting in relationships after their medical event? So we'll hit some of those different domains in intervention. So now that you've got a handle on what PTSD is and what trauma is, I want to compare it to that enduring somatic threat that is ongoing. One major difference is that PTSD is something that happens kind of outside of you, it happens to you, whereas with enduring somatic threat, it's something that's happening within you. You can't kind of shut it off and walk away from it. There's also a past focus. PTSD has that word post in it. The implication is that the thing is no longer happening. With enduring somatic threat, you may be considering the thing that's happening within your body right now or the threat that it presents to your future. Hypervigilance describes PTSD, but it doesn't really describe enduring somatic threat very well, because when you have a life-threatening medical condition or something chronic and you have to maintain that over time, you really need to be vigilant. You need to watch your blood sugars, or you need to, do breast checks to make sure there are no new lumps. So this kind of goes along with the intrusive thoughts as well. Those things may be just a matter of fact for your daily life now. And traditional PTSD assessments may miss them because it's just an expected thing rather than an intrusive thing. Avoidance is another one with PTSD. Someone may want to avoid whatever is triggering them, like a loud noise. With enduring somatic threat, folks may try to avoid taking medications, going to appointments, talking about their medical condition. And unfortunately, that can be dangerous if they have something that really does need to be managed. So let's talk about how this plays out into some of your patient populations. Cancer is the first one. 20% of folks who have early stage cancer and 80% of folks with recurring cancer have signs or symptoms of PTSD. 4/5. It's just such a huge percentage of people experiencing recurring cancer. I would argue that maybe that's not disordered. Maybe that's just the way that humans process this life-threatening problem. So now we kind of get to go back to the physical medicine side of it. How does trauma impact your physiological symptoms? Trauma interacts with both your sympathetic and your parasympathetic nervous systems. The heart rate's going to go up, blood pressure, respiratory rate. You might notice that patients are more easily overloaded. They can't down-regulate their nervous system. There's even been changes to gene expression identified after someone experiences trauma. So what does that look like in rehab itself? Depression can cause memory impairments, increased motivation. Changes in the parasympathetic nervous system can cause orthostatic hypotension, and there's research behind the impact of trauma on orthostatic hypotension. Changes in all of these other issues. So if you've got a patient who you've referred because they've got some mental health issues, you may notice that their stress is inducing some of these other changes as well. Talking again about specific populations, these are folks who have survived an acute life-threatening medical event. 12 to 25% of them have clinically diagnosable PTSD. And the percentage who have symptoms is even higher. Folks who have a coronary syndrome, for example, 50% of those folks still have symptoms of PTSD after 8 years. Now, let's talk about those symptoms, hypervigilance, avoidance, and intrusive thoughts, and how they might play into a feedback loop with medical conditions. Cardiovascular risk is a big one. So if somebody's got an acute coronary syndrome, that can lead for them to have post-traumatic stress. And then now they've got all of those physical symptoms, right? Even just increase in heart rate and blood pressure is going to make a big difference for that person. It can cause an increased likelihood of further coronary events. Now, if we talk about avoidance, I mentioned this a little bit earlier, but it can cause a decrease in patients' medical adherence, whether that's medications or participating in further screenings to monitor their condition. It just reminds, in breast cancer in particularly, it reminds folks of their body's fallibility. It can also induce pain, and it can cause re-experiencing of their traumatic event. Now, this third one I told you doesn't really fit. PTSD treatments may not be helpful because what am I going to do? Expose you to that medical thing again? Maybe there's not really a way to do that for you because we don't need to do the biopsy again or the treatment. Some questions that psychologists might use to either screen for or assess PTSD may not really make sense for a patient who has medical trauma. For example, one popular screener includes the question, I found myself acting or feeling like I was back at that time. Well, if your trauma has a present or future focus, that question doesn't really even make sense. I'm living in my body that currently has cancer or a disability right now. So there's not really a back at that time source for my trauma. This leads some researchers to suspect that medical PTSD is really identified in the literature. Patients who experience PTSD symptoms but don't have clinically diagnosable PTSD, it's much more common to have the symptoms, especially in certain diagnoses like myocardial infarction. Okay, there are enough of us here. I would like to do just a minute or two of reflecting, interacting with folks around you. I'd like you to think about one patient who maybe you noticed they dealt with a lot of that hypervigilance or non-compliance or avoidance for their medical conditions. Discuss any traumatic events they might have experienced within the healthcare context. And then we're going to take that forward with our future conversation. Since thinking about this, I've had patients in every setting that I notice have symptoms of this hypervigilance or noncompliance or PTSD. You know, patients in outpatient, absolutely. Patients in acute care, 100%. So we'll think about those guys as we move forward. Now, I want to talk about some things that contribute to the development of medical trauma or maybe protective against it. In the last several years, a lot of researchers have noticed that there's a kind of a perfect storm with COVID in development of medical trauma. Quarantine, absolutely, lack of information, the specific things having to do with your ICU stay that may develop medical trauma are if you have an ICU stay for a lung or respiratory injury, or if you have a lengthy sedation, both of which are very common in the treatment of COVID-19. There's also some just demographic or patient factors which may be predictive of PTSD depending on how it's assessed. Patients who are younger, who have lower income or fewer years of education, patients who feel out of place or report a large memory of pain early on in their recovery, or patients who recall being in the ICU versus who were sedated, which is kind of contrasting to the heavy sedation I mentioned a minute ago. Some patients are less likely to develop trauma based on their personality factors or their diagnosis factors. Some patients may be more likely to develop PTSD if they have a history of neuroticism or a prior mental health condition. And of course, if the diagnosis is not very severe, they're less likely statistically to develop trauma. But the last couple of slides have a bit of contradiction. You know, some patients who have lengthy sedation may have more likelihood to develop trauma, but then I said that patients who have memory of ICU events do. So I think the overall impression I get from the research is you never know which of your patients may be more likely to develop trauma. So assess them with open eyes. The one thing that is consistent is staff communication. That has a massive effect on whether or not our patients are going to develop trauma. Yikes. So if you have the ability to deliver accurate, timely information, you have a greater influence on the person's development of trauma than, for example, their cancer severity. So the influences of that communication system are all things that are outside of the patient. The stressors on the staff member's experience of vicarious trauma from other sources, the workplace culture. If you're a perfectionist, I'm sorry to say, you're more likely to cause trauma in your patients because of your stress level. So this is important work. It's just really important to take care of yourself. Especially if you work with a patient population that has a high likelihood of trauma. Unfortunately, anti-minority implicit bias in healthcare providers is really well documented. This can cause patients to experience stress, and research shows that some minority patients have measurable physiological stress before they even go to doctor's appointments because of their anticipation of experiencing bias. It can also cause providers to make unintentional errors. For example, research has found that doctors screening for depression use statistics about the patient's race to make decisions, even if it was at odds with the clinical presentation. So bias can be even more harmful in clinicians who don't recognize their own biases. But the silver lining is that folks who do recognize and work on it can adjust their biases. So just a really important, knowing how important patient communication is to make sure we're always constantly examining our own biases. Another staff factor, again, has to do with our recent pandemic here. Those staff members who had a high desire to help others, really go-getters, they experience a wider variety of PTSD symptoms, more exhaustion, more depression from the pandemic. We don't have research 3 years out from COVID, but we do from SARS many years ago, and effects of quarantine on those staff members was felt up to 3 years later. So that, again, just managing our own stress is super important for the well-being of our patients. What are some other factors that don't have to do with us? If we manage the environment, that can be a huge help for our patients. Medical environments are full of stimuli that you don't really find anywhere else. Some of it we're kind of numb to at this point, noises and beeps and smells. Even the taste of applesauce can be triggering for some of our patients. There's also kind of a deal that you make when you experience medical care where powerless is kind of a part of it. You have less control over who is in your room with you, who touches you, when, and for how long. So the very existence of healthcare environments can increase patients' likelihood for trauma. All right, now for the best part, what are we going to do about it, right? Acute care has some pretty heavy research on how we can manage medical trauma. In 2020, a randomized controlled trial found that an ICU journal that was interdisciplinary prevented symptoms of hyperarousal at 3 months post their ICU stay. We can also be very careful about early pain management. Early pain predicts the development of chronic pain, and chronic negative emotions can cause a hyperactive pain response. Think about that hyperarousal that we talked about earlier. So what can we do? We can manage that pain. We can offer patients control over their environment. We can ask for consent each time we touch the patient, and make sure that if we're moving things in their space, that we get their consent for that as well. If your patients have to experience isolation or quarantine, it's actually better to over communicate with them, even if you're not sure when the quarantine will end. You can reduce boredom and think of their activities as part of their healthcare, because it does mitigate their likelihood of developing mental health issues in the future. Patients who are bored may let their fear kind of run away with them. And now let's say they get to rehab, kind of out of that acute stage. What can we do as rehab professionals? There's a few of those 8 crises that were identified as faced by patients with medical trauma that I thought really lend themselves to rehab therapies. If patients are struggling with a crisis of identity, we can help them identify their strengths, notice that, how much progress they've made in rehab. We can address barriers to developing relationships if they're having trouble communicating with their loved ones. We can help reframe if they're feeling like they're really out of place or out of time. The use of incontinence products in a young person, for example, can we help reframe that a little bit for them? And we can use hobbies kind of as a gateway to address their other more physical needs. If there's a runner that you're working with, you may try something like an endurance task of some kind, or creating a project for a crafter. Another concept that has been recommended for physical health professionals is to help folks with making meaning out of the experience they're going through, encouraging the patient to sort of write a new story, start a new chapter by learning about their illness, or just encouraging them to talk with you or with their family members. Medical trauma can be a catalyst for significant growth and discovered meaning. I just love that quote because it it reframes, it's just something that we all go through. It's not necessarily something bad to experience trauma. Now, if you have a patient who you're starting to recognize that they are having some of those dissociative or shutting down symptoms, maybe you're asking questions and their only answer is, I don't know. This may be some of that acute stress disorder. So what you want to do is you want to just avoid debriefing. That's the space for a mental health professional. You may try to change your approach. Maybe right now they really need some kid gloves, or in the future they might need you to kind of be a drill sergeant. And then of course you want to refer these folks to a mental health professional. Patients who might be at risk, there's a handout that I put forward called the Medical Mental Health Screening Tool, or just write that down. It's freely available online. If you notice those dissociative symptoms, especially if they last more than 3 weeks, those symptoms are not likely to resolve on their own, and they probably need a mental health professional to do some cognitive behavioral therapy or some other treatment with them. So now you've recognized that you're going to need to refer. Now what? There's a concept called psychological first aid that physicians and providers can tackle in order to kind of help their patients get onto that next step. Stabilization is a good one. Remember that folks may be sort of disconnected from their own body. If you can do some symptom management, helping them to address pain or recognizing sleep symptoms, even if they're not really recognizing things in themselves. You can gather information to include with your mental health referral. Make sure the patient isn't having any suicidal thoughts. I know that's sometimes a hard question for therapists to ask, but it's important. And also just asking about their medical compliance. You know, I hear if I'm working in cognitive rehab on medication management, I don't know how many times it's been that I've heard them say, well, I don't think I need that anymore. You know, making sure that you're getting the right information to the right place. If the patient's not taking a medication, make sure you get that to the physician and the pharmacy so they know. And then discussing an action plan, it may be helpful to actually write it down. Remember that depression causes memory problems. And so if the patient's experiencing that, they may not remember what you asked them to do or follow up. Okay, now let's do some real life case studies. We'll kind of hit your case that you mentioned at the end here. I've organized these by different, those levels of medical trauma. Remember that even a routine procedure can cause medical trauma. This is the experience of the author, Michelle from Hall, that I mentioned before. She had a really traumatic childbirth, which it took her a very long time to get help for. I've selected some quotes about her experience that really could apply more broadly to our rehab patients. She said, I wasn't suicidal, homicidal, or psychotic, so no mental health professional was called to consult. And her discharge instructions were ordinary instructions for the most extraordinary of circumstances. It may be easy to forget when we do this every day that the experiences our patients are having might be a lot for them. Another more routine care could be pain management. In another book, African-American patient encountered providers who did not take her pain level very seriously. She was so sick of hearing that it was very common that you would have this regular amount of pain every day until she reached a provider that really understood her. And then after that experience, she had trauma trying to interact with new providers in the future. I had this patient, she was my own. She's really sweet, 99-year-old, but once the facility shut down for a COVID quarantine, it was really difficult for her. She was not a patient who was typically anxious or upset, but she would not stay in her room during that quarantine time. I think she was really feeling out of time or experiencing almost like an identity crisis, like I'm 99, let me go out of my room. So that was really routine care for us, but for her, that was just too much to ask. And then finally, this is the experience of my husband. So he had all of those 8 crises come up in his life. In an interview I did with him, the thing that really got to him was doing physical exercise. He had such difficulty doing the exercises when he had hemiparesis that he felt it was doing more mental harm than physical good. So now I want to get back to that case study that you had. Just take another minute or two talking to folks. And I want you to think about interventions in particular. What could you have offered to that patient? Could you have offered symptom management? Could you have offered a little more meaning making or kind of reframing for that patient? And did you refer to mental health, and would you do it differently now? All right, thank you. During our, just have one little more intervention, and then during Q&A, if you guys want to kind of speak about your experiences, I would really love to hear them. So for game plan, I want you to kind of maybe take one of these or one other thing that you can pull away from the presentation and change in your practice. Maybe you want to print out that medical trauma screen that I mentioned earlier. Maybe you need to just check in with your mental health referral network and say, hey, I want to just let you know I exist. I'm going to be sending patients your way, so that you kind of built that relationship ahead of time. Maybe you want to just check in with, I don't know if you guys have surveys, or check in with your patients and see if there's anything that you could be doing better to set up their environment, or talk to the nursing team about an ICU journal. Think of one thing that you can do pulling forward to kind of address medical trauma in your practice. And yeah, references, that's it for me. Thank you guys for having me. Any questions or comments about your individual case study? Go ahead.
We're seeing more anxiety than we've ever seen before since COVID, and
yeah,
like you said, the quarantines and lack of seeing people, and
yeah,
not seeing a medical provider for a couple of years, and then bam, they've got cancer.
Right. So she was saying, for the folks online, she was saying there's an increase in anxiety in folks, maybe not even wanting to seek medical care until they've got something major wrong, like cancer. Yeah. I even think about the relationship between breathing and anxiety. You know, if you go to the hospital with a breathing problem, they're not going to give you an anxiety med because it can decrease your breathing rate. So there's just such a strong physiological relationship between anxiety and mental health and physiology. Maybe even building an outpatient list, you know, that you can provide to patients at discharge. I know there's like Pando geriatric counseling is a really big counseling practice for elders in our community. I'm sure there's lots of others that serve younger populations. Yeah, I love that. I'm just going to try and repeat what you said for the online listeners as well, but she was talking about the head and neck doctors giving the advice to their patients that you're kind of in fight or flight mode, and even taking anxiety medication short-term may be helpful for your long-term recovery. Yeah, absolutely. Kelly was mentioning that in that head and neck cancer population, you hear a lot about non-compliance with medical recommendations, whether it's follow-ups or whatever. But yeah, that word non-compliance is really loaded, like that word behavior. Maybe it's distress symptoms, maybe it's more mental health than we realize, because everybody wants to get better, right? And maybe they're not, maybe there's a reason, a mental health reason why they're not able to handle another appointment today. Yeah, so you're talking again about not only PTSD from maybe the surgery, but also the enduring somatic threat of the threat of cancer coming back, right? So now you've got all these medical things to manage now, but I also have to think about my future, and it's pretty big recipe for trauma. So yeah, thank you all for having me. I really appreciate it.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.